is really required compared to this. We have a very experienced person, Dr. CV, Dr. Gopichand as a surgeon. CV is talking in favor of TAVR, and Dr. Gopichand is talking in favor of SAVR. I think understanding this difference, disadvantages of the percutaneous treatment and the surgical treatment is very, very important before we embark in these technologies. I think Dr. CV is going to enlighten us regarding the AVI, and I asked Dr. CV.
Thank you, good afternoon, and thank you always for giving us this. The world of cardiology has actually seen three major paradigm shifts. The first one was in 1977, as we all know, that angiotensin started the coronary angioplasty. And then followed in 1996 with first coronary stent replacement by SAVR and TAVR. And then came in 94 when we were the residents, and we were very excited about these two landmark trials, that is ministry stress cardiac surgery and and then it took almost a decade and a half for the next paradigm shift to happen in cardiology, which we call as TAVR. Martin Lyon in his landmark article, which is published in NEJM in 2011, has paved the way for a remarkable change in the way in which we were treating cardiology and structural heart programs. So, actually, today's topic is a kind of a debate, they name it, but then the arena or the entire story is still evolving. There is no, as the previous somebody had spoken about some area like obesity or IVAs, they are each complementary. Similarly, TAVR and SAVR are both complementary, and we cannot really say that this is the cohort which only TAVR is important and this is the cohort only SAVR is important. There is no firm cleavage. So it is important for us to understand that there are specific situations where the TAVR is extremely useful, and there are some cohorts or arenas where the surgical atrial replacement still holds the priority in patient care. Having said that, today's debate, we have a very, very strong opponent in favor of SAVR in the form of Dr. Gopichand, who is a doyen of cardiac surgery in our state as well as in the country. And I am supported by the world literature and the accumulated experience of TAVR and my own experience in my own clinical practice. So let's go through the whole story. So whenever we are talking about an aortic stenosis, the patients do come, we are supposed to risk stratify them into high risk, intermediate risk and low risk. And there are several risk scores that are available. The famous ones are STS PROM, and then of course the Euroscope 2, and based on which you triage the patients into risk categories. And as far as the high risk zone is concerned, only mortality improvements matter. The rest of the things really do not matter because, like for example, we are talking about acute kidney injury or some bleeding and all that, because it is any treatment modality in a very high risk zone is what matters is the patient should be living whatever you do. So it is a mortality benefit that you are looking at when it comes to the question of high risk. Whereas whenever you are talking about intermediate and low risk, a host of other issues also need to be considered, because it is not just mortality, because a patient who is belonging to the intermediate or low risk category will have to live and also will have to live well. Not just live, but will have to live well. So the host of other issues also need to be considered, like atrial fibrillation and paravalvular leaks, acute kidney injury, vascular complications, associated coronary artery disease, access issues, and so on and so forth. So when you are making a choice between TAVR and SAVR, So in intermediate and low risk categories, it is not just enough. If you talk about only mortality or a stroke, you have to also consider the other major issues which make a lot of difference to the patient's life once the procedures are done. As a snapshot, if you have to talk about SAVR and TAVR, the mortality and stroke are better with TAVR at the early time points after the treatments. For example, at perioperative or pre-procedural outcomes, or at 30-day outcomes, or at 1-year outcomes, the TAVR generally is far, far better in terms of mortality and stroke. But if you look at 5 years, the outcomes, they even out, and the TAVR is non-inferior to SAVR. The second important issue is, as a general rule, acute kidney injury, bleeding, atrial fibrillation, and resource utilization is far higher with SAVR as compared to TAVR. But the SAVR scores in two arenas significantly in terms of parallel leaks. Parallel leaks are significantly higher with TAVR compared to surgical atrial valve replacements because of the various technical issues. Similarly, the new onset bundle branch blocks or the need for permanent pacemaker implants are higher with TAVR, especially with balloon expandable valves, not with the self-expanding valves, not balloon expandable valves. So the other important snapshot is a very large cohort of aortic stenosis patients is excluded in the major clinical trials. For example, the low-risk trials that have been published in 2019, they have an age group of 70 to 74. So if you just take the cutoff of 70 years for the low risk, anything less than 70, especially the bicuspid valves and bicuspid valve-induced aortic stenosis and so on, they are largely excluded from all the clinical studies. So we really don't know what would be the ideal treatment choice in this particular cohort. And actually, if you really look at our own population, the aortic stenosis comprises of less than 70 years, not to a very little degree. The huge body of patients where the aortic stenosis is significant, less than 70 years old. So the answers to this particular cohort is not very clear in the world experience. So what I'm going to do is I'm going to navigate into the next few minutes by the risk categorization and the only major landmark trials and the experience there. Because it's very important, it will be very difficult for me to really narrate and then explain and then expound the various trials that have come in. I'm only going to stick to only the landmark trials in the TAVR landscape. So when there is an extreme, there are high-risk trials are two. Classically, partner 1 and US pivotal core valve trial. Intermediate risk trials are partner 2 and SAVR, and low-risk trials which are published in 2019 are partner 3 and low-risk core valve study. Coming to the high risk, partner 1 actually had two cohorts. One is partner 1B, where the surgery is totally unsuitable. Surgery was excluded, patients were refused surgery, and the patients were given TAVR, and then they were compared to the standard therapy, which was an optimal medical management. So obviously, the TAVR has resulted in a significantly improved death and stroke and rehospitalization and functional class. It is understandable because basically from nothing, patients did get some kind of a treatment. So that is a foregone conclusion where the very, very high risk and surgery is unsuitable, TAVR is the choice. Whereas partner 1A cohort is associated with a very high risk offset, wherein the TAVR is compared to SAVR. Again, TAVR scored considerably higher or better than SAVR, except in stroke, where the TAVR was associated with a higher stroke rate. But the point to be noted here is these were all very early days where the TAVR was done with a very first generation transcutaneous heart valves. And also the technology and the technique of doing the procedures were also a little rustic. So the TAVR was associated with stroke, and subsequent experience as the story evolved, the stroke rate has come down significantly with TAVRs. So looking at the 5-year data of partner 1, compared to the standard treatment group, which was medical management. As expected, at 5 years also, the mortality and stroke rates, the TAVR scored considerably better than the standard treatment periods. The important issue here is that, of course, the other indices are the echocardiographically, then the patients are looked at the 5 years. The durability of the transcutaneous heart valves, which is an important issue, because as the time passes, there was always a doubt whether the transcutaneous heart valves are going to perform well or not. Even at the end of 5 years, the ideal valve areas are around 1.5 and mean gradients were very low, so which really proved to the world that yes, the heart valves are completely durable and they are sustainable. The second high-risk study is US core valve high-risk study. Here, if you look at the 1-year mortality, there is definitely an improvement compared to the SAVR. And at 5 years, the mortality and the stroke rates evened out between the TAVR and also the SAVR. Again, the TAVR is non-inferior in this particular part, even at the later endpoints or time points at 5 years. Coming to intermediate risk, then the focus shifted from very high risk because it's already confirmed and a very clear benefit that the TAVR had produced in comparison to TAVR, in comparison to SAVR in high-risk zones. So the expansion and experience has got into intermediate and low-risk zones. And Partner 2 was published, and wherein the all-cause death and stroke were significantly lower in TAVR. But then, statistically speaking, the statistics showed that the TAVR and SAVR, both of them are non-inferior to each other at the 2 years in intermediate risk. But when they're talking about all-cause death and stroke, the TAVR was done from multiple puncture sites. The TAVR was done from transclavian, transcarotid, and also transapical. And if they looked at transfemoral TAVR, there were low rates of death and stroke compared to SAVR. So when they included all the axes together, the TAVR was non-inferior to SAVR. But when they looked at only transfemoral TAVR, then the TAVR scored over the SAVR. And because it is intermediate and low risk, the other issues also come into play. The TAVR was associated with larger aortic valve area. There was less fibrillation in AKI, as we mentioned before. There were less vascular complications and less PVL with SAVR, as expected. So this is again non-inferiority, and curves were merging at 2 years. Stroke, and then the anesthesia time, procedure time was significantly lower or less with TAVR as compared to SAVR intermediate in Partner 2. The median ICU stay and LOS, which are very important surrogates for doctor managers today, is far better with TAVR as compared to SAVR. AVA, as I said, it is better with TAVR. Parallel registration is definitely more with core valve, that is self-expanding valve. So they found that moderate to severe parallel leak is higher with TAVR. Compared to the intermediate risk with self-expanding valves, again, there is a lot of improvements with the aortic valve area, and the aortic mean gradients were lower with TAVR. And mortality and rehospitalization is far better with TAVR. But again, in intermediate zone in the core valve also, the TAVR was non-inferior to SAVR. So coming to the low risk, this is the most contentious area because initially after the FDA has approved TAVR as a treatment modality and gave the classical indication for TAVR in low risk, there were several criticisms about the decision because people even questioned the way in which the Partner 3 trial was formulated. But whatever it is, the partner 3 low risk has shown that the mortality and the primary endpoint, all-cause mortality, death, stroke, all of them scored better with TAVR than SAVR. Even at the end of 1 year and also 2 years. And patients' symptomatology is also much better with TAVR. And 6-minute walk test is better, and the quality of life indices is better. And the Evolute low risk trial also has proven that TAVR is non-inferior to SAVR, including mortality and hospitalization at 1 year and stuff. So in almost all patient metrics, the TAVR was non-inferior to SAVR, both in intermediate as well as low risk categories. The only 2 issues with TAVR were, one is the need for permanent pacemaker implant, which is higher, and second is anything moderate to severe paravalvular leak is higher with TAVR. Whereas mortality, rehospitalization, quality of life indices, patient prosthetic mismatch, AKI, and atrial fibrillation, everything is far less compared to surgical activity. So intermediate low risk, in fact, they said there was a meta-analysis of all the low risk and intermediate risk trials, where they finally concluded among older low risk patients with severe aortic stenosis, TAVR was associated with a low rate of death and disabling stroke compared to SAVR. But then again, the quality of life, reduced bleeding, atrial fibrillation, higher paravalvular leak, pacemaker implant rates, they're all, as expected. So how do we go about now, which is particularly important for our patient population? As I said in the opening issue itself, there's a very large cohort of patients, less than 70 years, about which we don't have any answers. And that is part one. Part number 2, all said and done, there is a huge learning curve for TAVR. And my own experience of say 8 or 10 cases, and I'm sure that other people also would agree, the learning curve is not that easy. Because basically the more the number of patients that we do, the more obviously we get the experience, and then the outcomes also will be better. Having said that, the getting into the TAVR zone is associated with a lot of financial issues. So that also becomes an important issue when once you are talking about improving one's own learning curve or improving through that, navigating through the entire landscape of TAVR. So keeping that in view, I don't think we can just offer TAVR to each and everybody or each and every person with aortic stenosis at large. We need to have a kind of balance apart from the technology itself, which is still evolving. There are so many unanswered questions. For example, they said that if you really follow the CT scans of the TAVR, post-TAVR, the leaflet thickening of a particular cutoff points may be associated with a thrombus. And whether these particular issues need to be treated with anticoagulant or no, well, they are associated with any delayed strokes or delayed embolisms. We have no data. And then, when once the TAVR, the transcutaneous heart valve, got into degeneration, then what is that? What is the story after the degeneration, after the PVL? We really don't know. Now, PVLs can be closed. That's not a problem. PVLs can be closed transcutaneously again. We can put some plugs and then we can close those leaks. And the pacemakers, we all know what is the morbidity associated with pacemakers. All said and done, if you really see the pacemaker implants and then with a dual channel pacemaker, the patient's ability or patient's performance in terms of quality of life and going into a kind of a heart failure are the real world scenarios. So, in other words, in short, we really don't know the longevity of the TAVR and what are the futuristic issues with the TAVR. But to give a generalization, in high-risk zones, there is absolutely no confusion. The patients will do well with the TAVR as against the SAVR, because SAVR is definitely associated with much worse performances in high zones. But as far as intermediate and low risk zones, it needs to be a kind of an informed, shared decision, including the cardiologist, cardiac surgeon, and then of course the patients and patients' families, fully understanding the implications into the future. Unless we really consider all the parameters, we can't really jump into the fray and say that TAVR is the treatment. So because there are so many unanswered questions in this area. So that's where I stop, and then I allow Dr. Gopichand to take over. And then I'll give you my final verdict. So it's slides.
Sir, yes, please. The next talk I invite Dr. Gopichand. Dr. Gopichand does not require any introduction here. Everyone knows him. He's a big name in cardiac surgery and he is known worldwide. Not only in the medical faculty but also among his patients. Everyone knows him. I hear many great cardiologists talking about him. Any complex case, only Dr. Gopichand can do this. So that is his name. Sir, please take over.
Thank you. What I have to say on this matter. In structural heart treatment, there's always this dilemma. The picture on the right side is in our college, medical college, Gopichand Medical College, and that's TAVR guy not even showing his face, but trying to make an impact. I hear what Dr. SAVR has to say, and I'm sure a lot of the audience believe that we have found a new way of treating aortic valve stenosis. But there's a long way to go. The road is still very, very long and bumpy. I remind all of you, especially physicians, about William Osler's quote, famous quote, a good physician treats the disease, but a great physician treats the patient who has the disease. So we should not lose the sight of what we're trying to achieve while we're attempting to help a patient for a better life, both in terms of longevity as well as the quality of life. Yes, we have a new gadget, but is it the right thing for everyone? So we have to strive to find the right indication for this new technology. It is here to stay. There's no doubt about it, and it has a place to play its role. But what is that is still unclear. So if each one of us have an option, then we will use only one procedure, one valve. But we're not there yet, and I don't know whether we will ever be. But that's the ideal. So against that ideal, we need to understand where we are and probably work towards it. I want to give you a couple of scenarios I faced. One is this young lady, 29 years, who has dyslipidemias, patches all over the face and other places, deposits of lipids, has class 3 symptoms and has severe aortic stenosis and needs treatment, but she desires to have children. This is a doctor from Vizag, who is a 62-year-old. My wife is also a doctor. 2 years history of glomerulonephritis, severe proteinuria, and he's on imidacloprid. And he has severe aortic stenosis. So the potential surgical complications are worsening of renal function, needing dialysis, infections because of the immunosuppressions, poor wound healing, and possibility of future renal transplant. So this is the kind of practice we are in every day. Trials, randomized control trials, and individual experiences published is one thing, and we have a patient sitting in front of us. We have to make sense out of what is written and what is our practice, what is our experience versus what we do with this particular patient. This is all philosophy. But generally speaking, if you have a 60-year-old, this particular doctor, if he were to have a SAVR at the time of presentation, he would probably need 2 surgeries if there is a tissue valve, if he lives long enough. If you start with TAVR, he may end up with 3 procedures, either 2 valve-in-valves, TAVRs, and then subsequently SVR. As of now, that's the experience. And we can have 1 mechanical valve with its own separate set of complications. It's further complicated by introduction of new technologies, new ways of achieving what we achieve in terms of surgical techniques, and of course new knowledge accumulation, and every few years changing guidelines. So these are some of the things that we have to work with and yet customize the treatment for a given patient. And these are some of the things that, especially the longevity, patients' expectation about the quality of life, what they want to do in their life, and of course, professionally, not all of us are exactly what we call as balanced, and of course informed. Patients' expectations and gender issues. This is the current expectation in life at birth in India and other places. I believe we are at 72 years, and COVID actually reduced 2 years. But it's going to get back to that level, and then we'll probably achieve the target even before we reach 2050. So coming to the published data in the literature, some of it was shown by Dr. Sirao. In my mind, and I'm sure you'll agree, that all these parameters, all these variables need to be addressed if you have a complete paper. But what's currently happening is that people are picking a new technology compared with an older type of operation, and then coming to a conclusion conveniently for their advantage, perhaps even supported by the industry. So we cannot, as responsible doctors who need to deliver the right care for our patients, we cannot fall into these traps. It's very important that we need to understand everything that is to be there, to be understood, and then give the right kind of treatment. And for instance, in Partner 3, overall mortality, stroke rate, and readmissions were addressed. And based on that, they recommended that surgical aortic valve replacement is inferior to TAVR, so go ahead and put TAVR valves in every aortic stenosis, which is not the right way in my mind. And there are other things that also need to come. So all these things and the implications of these variables on the longevity and the quality of life of the patient matters. And only then that paper is complete and that we can follow the recommendations for that particular paper. I want to show that this is an STS database publication done in 21. We're also contributing to this STS database from the last 1 year, and we will have our own data analyzed and published. This is very extensive data, more than 1 lakh patients, 1,22,000 patients are included in this. I'm showing this to tell you what's the real life surgical aortic valve replacement outcomes. especially if it is done with minimally invasive aortic valve. If you look at the two second and third, the partial sternotomy and the right thoracotomy, anterior thoracotomy, these two are minimally invasive valve replacements. In the entire cohort, there are about a quarter of the patients. And overall unadjusted operating mortality is 1.9%. If you take a low risk group alone, it's 1%. And yet, these are some of the variables I will actually have to allude to, but the partner 3 shows that surgical aortic valve replacement has 9.3% overall mortality and stroke rate. If you look at operational mortality of the partial sternotomy or right thoracotomy, it's 1%. Okay? And undisputed, this is with a large cohort of patients. Same way with permanent stroke, 1%, 1.1. Prolonged ventilation, 1.1. New onset renal failure, less than 1.7%. And postoperative length of stay, less than 6 days, is also very, very good. Transfusion, new onset atrial fibrillation, all of them are 1 or less than 1%. I just wonder why the partner group, the first author is a surgeon. Michael Mack is a very renowned cardiac surgeon from Baylor. Why they did not consider this as an important number to compare with, and why New England Journal decided to publish it is beyond me. So it's important to stop and think, is this what's been presented in partner 3 is correct or not? So the minimally invasive aortic valve is associated with lower rates of blood transfusion, lower rate of atrial fibrillation, new onset atrial fibrillation. Postoperative pain, of course, is very low and shorter length of stay. We've done over 200 isolated aortic valves through minimally invasive surgery, both transaxial and anterior thoracotomy, less than 4 days. As Dr. Venkatesh said, it's important, ALOS is important for, I'm also an administrator, so I also get that number. So it's 4 days or less. Some people went home in 3 days. So these are the new ways of doing aortic valve replacement, and if TAVR need to be measured, that need to be measured against current advanced technique. Then only it gets validated. So, this is what bothers me. He's a physician. This is published in a British Cardiovascular Society published this paper. The man says, partner 3, the death knell for surgical aortic valve replacement. Is this a way a responsible physician should behave? And that's published in a society paper. And this guy is supposed to be an Indian. I don't know where he is, but the point is that people get carried away without even understanding what they're trying to do. And these are some of the, which are already been alluded to. I don't want to spend a lot of time, but all of them show, partner 1, I would say we should exclude it because it's very high risk and even not suitable for surgical patients. So we're not even talking about that. But we are definitely talking about partner 2 and partner 3. And I'm going to show notion trial also. And this has already been 15 minutes. Okay. Partner 2, Martin Leon published it and says that it is non-inferior. I want to highlight 2 points here. The trial has recruited patients who have STS score between 4 and 8. But in the reality, only 20% of the patients have beyond 4, STS score beyond 4. 80% are under 4, which is low risk, yet called as intermediate risk, and show that it is non-inferior, which is not a a correct thing to do. You state upfront something and you do something completely different to achieve the goals of what you stated is not also correct. So the results of Partner 2 trial raised concerns whether the findings of these randomized controlled trials reflect real world outcomes. It's been pointed out time and time again but being ignored. And you keep wondering why. This is another point. So this is the Partner 2 group published 5-year follow-up. It's a very busy slide. You can see a lot of parallel links and other things. And you look at this structural valve, any cause and all those things. Again, it's very important. There is no mention of permanent pacemaker incidents. And it clearly says that 5 years, more patients in TAVR group than in surgical group had at least mild to moderate paravalvular leaks. Repeat hospitalization, which is again in Partner 3, it says that repeat hospitalization is less in TAVR, but Partner 2, repeat hospitalizations are more frequent with TAVR groups than surgical groups. Yet, in the conclusion, among patients with aortic stenosis who were in the intermediate risk group, no significant difference. How do we get to a point where you state something and then they infer something else? That's also another question. I mean, Partner 3, I want to tell you, Dr. Sira has shown this study design. I don't know how many patients, these are 1,000 patients, 500 in TAVR and 500 in one or two patients less in surgical group. But how many patients they went through to recruit 1,000 patients is not given. So there are multiple centers. We don't know what kind of valves they use. They said they recommended Edwards valve, which is pericardial valve, but we don't know which valve people used. Yet there are so many exclusion criteria. So without a number, a registry to say that so many people were screened for this study, and then 1,000 were picked up, which means that out of 20,000, you picked only 1,000 for your study. That means it's not a real life representation. If you only screened 2,000 and picked up 1,000, very close to real life. So without some sort of a perspective, it's very difficult to understand how many patients really end up needing TAVR in real world. We don't know. Because there's no registry, at least not published. And this is what I want to point out. I've already shown the operating mortality, the overall mortality, the stroke, everything is 111. I've showed you that we have a very large cohort of patients, yet we have this graph. And of course, and he says that, I also want to point out on the other side, the positive, the TAVR is superior, almost 46% reduction in risk. And 2 year, 40%, 37% reduction in risk. And remember that these are semantic, these are play with words. Suddenly in valve thrombosis, which is leaflet thrombosis, which Dr. Sivira has pointed out, suddenly the words changed. Till now, there's a superiority. Now suddenly it says that 97% don't have thrombosis. Instead of saying 2.5% patients may have had thrombosis, they've changed it to 97% is positive. All these things in my mind are either prematurely or wrongly interpreted, or they selected a set of variables which suits them to get what they really want to present at the end. As scientists as well as responsible patient people for treating our patients, it's important that we take cognizance of these things. This is another same slide, but I want to show you in the first 30 days, nobody would want to walk 6-minute walk test. So you cannot compare surgical patients who had a sternotomy at 30 days with the TAVR patients who had a puncture in the femoral artery. So I don't. It's not a fair comparison at 30 days, but 1 year they are same. Class 1, class 2, class 3 symptoms are same. If you look at Kansas City quality score, again at 1 year it is same. There is no difference. And these are stenotic patients, these are not minimally invasive patients. So, conclusion of the partner 3, without mentioning parallel leaks, without mentioning complete heart blocks, procedural failures or exclusions, it is excellent for low risk. So again, he's very generous in saying the limitations, but he also mentions about the problem of long-term structural valve deterioration. I hope I have 2 or 3 minutes more. I'm sorry. Because it's an important, I believe, discussion. This is another paper which published by the surgeons of Switzerland, in 2015, very long-term structural valve issues for surgical patients. Out of 383 patients, actually the survival is 10 years, and with a structural valve preserved 72% at 10 years, 46.2% at 20 years. And mortality for reoperation is 2.3%. There's an importance for this. If you have a structural valve deterioration and you need a replacement, second time mortality is 2.3%. But you know, if I have to explant a TAVR valve, which is happening now, is anywhere between reported published papers 11 to 17% of mortality, surgical mortality of explanting TAVR valves, because they're all incorporated into the important structures of the heart, outflow tract of the left ventricle. So, and then again, multiple papers showing the surgical valves, excellent long-term non-structural valve deterioration, 85% in some of the publications. Yet, Notion trial found at 6 years, 24% of the surgical valves there is a structural valve deterioration. This must be some kind of a miracle. Why surgical valves are deteriorating? In 6 years, a quarter of them where TAVR valves are only 4% structural valve deterioration. Don't you think something's amiss here? Whether they used porcine valves instead of pericardial valves, we don't know. So I'm trying to highlight the for want of a better word, and it's a strong word, manipulation of data, misinterpretation of the statistics, because you've already fixed your endpoints and you want to fit these things, so you come up with a recommendation. So these are the structured valve deterioration statistics of UK, France, and yet Notion trial has a different way of presenting them. Anyway, I'll probably, it's too much here. In this meta-analysis of 11 systematic reviews highlights the inconsistencies about reporting and presentation of data, most notably limited clarity on effects of risk bias on trials is very, very important. I'll show you this. This is one of the patients sent to me by a colleague who had TAVR and left-handed descending artery stenting, proximal left-handed descending artery stenting, presented now with angina, has very tight ostial circumflex and OM1 osteoproximal lesion. What do we do for that? In spite of all this data and published works, the 2020 APCSI guidelines did not put TAVR as class 1 indication. It is still, if it is below 65 years and they can have a mechanical valve is the first option. And then second option is between 65 and 80, SAVR is the first option, unless patient insists. Then comes beyond 80. You can start talking about both surgical and TAVR valves based on the risk stratification according to STS database. I want to tell you STS database, STS risk score and Euro 2 risk score both over predict the risks. We've done this in our hospital with our own personal experience. Both scores currently over predicts the risk, which means what you call as intermediate and high risk according to STS score is not really intermediate score. It could be even lower risk groups. It's also evolving science. In spite of that, the algorithm, and this is another important paper, STS JCC registry, both of them, in spite of all the data presentation, finally came up with the same recommendations: mechanical valves, tissue valves, surgical tissue valves, and then TAVR. So, in summary, a lot of things that these are published data. I have also mentioned the references next to it. I'll just read them out and then close it. Greater than moderate paravalvulitis and permanent pacemaker implantations or conduction abnormalities was higher among TAVR group. After 5 years, 1/3 of the TAVR patients had at least mild paravalvular leaks compared to 6% of SAVR group. Within 2 years, cerebrovascular events, mostly ischemic strokes, occurs 5% of the patients in TAVR group. Durability is a question still. There's a substantial number of low-risk TAVR patients, 15%. The future correlated re-interventions to valve and valve operations are almost impossible and extremely challenging. These operations are challenging because of the hardware that is in our way to perform a safer operation. Operative mortality for surgical explantation of TAVR, as I mentioned already, is 11%, and in some papers it's 17%. So I'll leave that with you with this thought. Selection of procedure or valve. Important is aspiration of the patient and their life expectancy, socio-economic conditions. I did not even touch the cost. So I thank you for the opportunity.
Thank you very much, sir. Definitely, this is a new kid we compared to Dr. Gopichand. I think this TAVR is just 1 decade old. I think surgery has got a lot of experience in this field. So obviously, it is evolving, I should say. All of us convinced that the high risk patient definitely TAVR has got a definite role. Of course, moderate and low risk yet to be debated. Of course, we don't have long-term data on low risk. But we have convinced ourselves and convinced that the high risk situation, I think TAVR is definitely helping us in clinical situation. And I request Dr. Gopichand, what will be your approach in your hospital, being an administrator, being a very high profile surgeon in a hospital where patient comes with moderate to high risk patient, whether low to moderate risk patient. What will be your approach? Will it lead to cardiologist or need to have a heart team discussion before taking up these cases in clinical practice? Because I always debate on this.
We work closely, both of us, our cardiology team and ourselves. And even for coronaries or aortic stenotic patients, we offer both. Where it is appropriate, we offer both. Because we are offering minimally invasive surgery quite frequently, a lot of people choose that rather than TAVRs. I'm not refuting the fact the TAVR is here to stay. It is there. There's no two things about it. It has a role to play. What's being promoted is the way it is being promoted is not correct without data backing up motion. And the last slide Dr. Zero showed, Michael Mack is also part of that. So I don't know even what.
Any question, audience?
I think if you look at the new recent medical teams, Dr. Skyman, most of the procedures are done in TAVR, are done by cardiac surgeons. I don't know whether it's true. like Chicago Med or Good Doctor, in all these medical fiction which you get in Netflix or Sony Live, it's done by cardiac surgery. And somewhere, at the end of the day, the analysis of thoracic surgery says that it should be done like what they also should be trying under some cardiological training also.
Fact actually, Indian surgeons. Adam Neotrani is an Indian surgeon. Indian origin, but I'm sure the first generation is. So he himself actually backtracked now and says that the unimuscular code was his publication. So they are all backtracking now, maybe they are overshooting their own data.
One is we have to say that based on the body surface area, minimum is 19 and based on the surface area you can increase to 21 by large level to routinely do even through minimum basis. Total level is not 28. Second is it's important to understand whether the tissue pericardial valves or porcine valves. The pericardial valves wrap design versus inside mounting design now has a difference of longevity. So it's important if they are using tissue valves, which type also matters.